Good morning, everybody. Dr. Pradeep Srinivasan from Bangalore. A small video on the topic of transposition of great vessels. This is a very important cardiac anomaly because if you see the literature and if you see practically also, the most easily missed cardiac anomaly is transposition of great vessels. Before we go into the fetal echo, let's look at the anatomy. Now this is a heart where the atrioventricular communication or concordance is intact. This is the right atrium and this is the right ventricle. This is the left atrium and this is the left ventricle. So RA connects to RV, LA connects to LV. What does that mean? It means atrioventricular concordance. But now look at the RV. It connects to a vessel which gives rise to great vessels and continues as the aorta. So the RV gives rise to aorta. So there is right ventricular arterial discordance. Also look at the LV. It gives rise to a vessel which branches, and both the branches are pulmonary arteries which go into the lungs. So the LV connects to the pulmonary artery. So there is left ventricular arterial discordance. So atrioventricular concordance and ventricular arterial discordance makes this condition a complete transposition of great vessels. Please note, the veno-atrial concordance is normal, that is, the SVC and IVC connect to right atrium and the pulmonary veins connect to left atrium. So the veno-atrial concordance is normal. Now before going into the abnormal pathology, let us look at the normal fetal echo picture of an RVOT. So here we have the anterior right ventricle. So this is the mid-sagittal plane. You can see the spine posteriorly, the sternum anteriorly, and the anterior chamber is right ventricle. So from the right ventricle, we get the pulmonary artery which goes closely opposed to the retrosternal plane and goes posterior as a smooth, wide arc. And once the PA comes out, you can see the right branch pulmonary artery going off here. So this is the normal RVOT view. Now we have the LVOT view. So that's the LA, that is mitral valve, that is LV. From the LV we get the LVOT or aorta. You can see that this is the interventricular septum. So the interventricular septum is in continuity with the anterior wall of aorta. The mitral valve is in continuity with the posterior wall of aorta. So that's the normal anatomy of the LVOT long axis view, and you can see that this is called as the septo-aortic continuity and this is called as the mitral aortic continuity, and you can see that this interventricular septum and the anterior wall of aorta has a smooth, severely obtuse angle, and the aorta actually faces posteriorly. So this is the normal LVOT view. Now this is the aortic arch view. This is posterior, this is anterior. You can see the normal aortic arch arises from the mid-thorax, takes a sharp curve and continues as descending aorta. This resembles the handle of an umbrella. Now that's the RVOT view. This is anterior, this is posterior. So from the right ventricle, the pulmonary artery comes out and continues as the ductal arch, and below continues as the descending aorta. The ductal arch is a wide arch with no branches and resembles a hockey stick. So please memorize these looks and these views, because now a small aberration in the shape of these views will give us the diagnosis. Now here we have a 4-chamber view with a atrioventricular concordance. So in this case, when we see the 4-chamber view, this is the LA, this is RA, this is RV, LV, foramen ovale apparatus, left sided descending aorta, levocardia, this is left, this is right, and you can see the crux is found by a more apically inserted tricuspid valve, a more basally inserted mitral valve. So this is a normal 4-chamber view with atrioventricular concordance. This is the RV, which is more trabecular. This is the LV, which is less trabecular. So the RA connects to RV, LA connects to LV. So there is atrioventricular concordance. Now when we try to look at the outlets of this same patient or fetus, you can see that the LV gives rise to a vessel which actually does not look like the normal ascending aorta. We just saw the LVOT view which had a smooth curve with the aorta facing downwards. Now you see the LV continuing with a vessel with loss of that normal appearance, and you can see that this vessel is pointing more posteriorly, and subsequently when I trace this vessel, it actually gives rise to branch pulmonary artery and ductus arteriosus. So the LV, which is the posterior chamber, gives rise to a vessel which gives rise to pulmonary arteries or branches immediately. So the left ventricle gives rise to pulmonary artery. So there is left ventriculo-arterial discordance. Now we look at the RVOT. So that's the anterior chamber, which is the RV, and that gives rise to a vessel which is actually not flush with the sternum but pointing more posteriorly. And when I trace this vessel, it actually continues as the descending aorta and gives rise to great vessels. So the right ventricle gives rise to a vessel which does not branch immediately but gives rise to great vessels and continues as the aorta. So the right ventricle gives rise to aorta, and there is a right ventriculo-arterial discordance. Now when we put color and try to get our ductal arch, you can see that the normal ductal arch had an origin close to the sternum from the right ventricle and went flush posterior to the sternum and took a wide arch. Whereas here you can see the right ventricle gives rise to a vessel which does not follow that rule. It immediately goes a little posterior, it takes a bend here and then an anterior bend and then continues as the aorta. So that says that the right ventricle gives rise to aorta and the ductal arch is trying to resemble an aortic arch. So it starts anteriorly but has to go posteriorly and then takes a curve in the form of a umbrella handle and forms a descending aorta. So that is how the ductal arch would get disfigured in a transposition of great vessel. Similarly, you can see the aortic arch from the left ventricle. You can see that the aortic arch comes outside. Now the aortic arch is supposed to be in the mid chest, but here it will be a little more altered, and you can see that's the aortic arch coming out and forming the descending aorta. So the arches will not look like normal arches which we usually are able to easily demonstrate. So this will tell us that anatomically the vessels are not looking like how they should look like. Now let us look at cines to understand better. So that is a LVOT view. This is the LV and that's the aorta, and you can see that the aorta, when it comes outside, it turns down sharply and goes posteriorly. This is unlike a normal ascending aorta. This is behaving differently. So now look at the video again. So the LV gives rise to a vessel which goes posteriorly, and if you see carefully, this vessel will actually branch immediately here. Now we will look at RVOT. So here you can see that the RVOT gives rise to a vessel which immediately turns posterior. So you can see the bend here, you can see the posterior bend here, taking the vessel away from the sternum. So the RV gives rise to a vessel which does not behave like the ductal arch or pulmonary artery. It is behaving like the aorta. So look at it again carefully. So now when the RVOT view we take, there is a step down and the vessel continues, and you can see there is no immediate branching. So that we know that the RV is giving rise to a vessel which is atypical of pulmonary artery, which doesn't branch and is a aorta. Now we will look at the 4-chamber view from below above, and you can see that there is no great vessel crisscross. So this is LV, this is RV, and when we come above the crux level to get the 3-vessel view, there is no great vessel crisscross. And you can see that from the LV, the PA comes out directly. From the RV, the aorta comes out directly. Both vessels are parallel to each other. I have other better videos for this. We will see that. So now this is the outlet, this is the view above the 5-chamber view where we normally get the great vessel crisscross. Now you can see that instead of crisscross, both will be parallel to each other. Now this is the left, this is the right, but from the left comes a vessel which branches, and from the right comes out a vessel which does not branch. Now we will play it again. So from below, so now you can see that from the left side comes out a vessel which branches, from the right side comes out a vessel which doesn't branch. There is no great vessel crisscross, and both the vessels are parallel to each other. Please take a good look at this example, because this is crucial to diagnose this condition. And if people overlook this step of the fetal echo, then the 4-chamber looks normal, the 3-vessel looks normal, and this diagnosis is very easily missed. Now in color you can see that this is left, that is right, that's IVC going to RA, this is LA, this is RV, this is LV, and now we are going above, and from the LV you can see the PA coming out, from the RV you can see the aorta coming out, and both the great vessels are parallel to each other and there is no crisscross. And you can see that the branch pulmonary arteries came out from the vessel which is coming out from the LV. So that's from below above. So that is IVC, aorta, RA, LA, RV, LV, and from LV, instead of the aorta, instead of going to the right, the PA comes out and stays on the left, and then you can see that will branch here. That's the branch pulmonary artery coming out, and this is the parallel vessels. So both the vessels are parallel without crisscross. Again another video showing beautifully the LVOT getting disfigured with the vessel pointing posteriorly and branching. So this resembles baby bird beak appearance. And now we have the RVOT showing the step down disfigured outlet, which is the aorta without branch and going to form the descending aorta. So the small disfigurement of the LVOT and the RVOT are the clues which we have to follow to diagnose this condition. And to clinch the diagnosis, we have to show the early branching pattern into both pulmonary arteries from the vessel coming out from the left ventricle. So that's the aortic arch. Note the small bend it takes after the arch comes out and forms the ductal arch, which is disfigured because it has to form the aortic arch. And now you can see a semi-coronal view where both the vessels are parallel to each other. So this is the best view to show the loss of great vessel crisscross, to show the parallelism of the great vessels, and to show that the vessel coming out from the LV branches, the vessel coming out from the RV does not branch. So now you see this video again, that both vessels are parallel to each other, and the anterior chamber gives rise to the aorta, the posterior chamber gives rise to the pulmonary artery. How did we know? This vessel which is posterior branched, this vessel which is anterior did not branch as soon as the vessels came out of the heart. Now that's again a 4-chamber view showing both the vessels coming out independently, and then we will look at the 3-vessel view now. Carefully look at the 3-vessel view. That's pulmonary artery, that's aorta, and that's superior vena cava, and you can see that the PAS is maintained but the A is anterior. Normally in 3-vessel view, the P is anterior, A is posterior, and S is still more posterior. That is, the pulmonary artery is anterior, the aorta is slightly posterior, superior vena cava is very posterior. So in complete TGA of the D type, the aorta is anterior. So there is loss of the normal alignment. The arrangement is normal, alignment is altered, and you can see that's P, that's A, that's S, and the A is anterior as compared to the P. So that's PAS. So the 3-vessel view also gives us a disfigured view, which tells us that there is a transposition of great vessels. So here from below above, we know atrial concordance, atrioventricular concordance, and ventriculo-arterial discordance with loss of great vessel crisscross, and with the pulmonary artery arising from the left-sided chamber, aorta arising from right-sided chamber. Here you can see the branch right pulmonary artery coming out from the vessel which comes out from the LV. So that clinches the diagnosis, and in this case there was no other anomaly, everything else was normal, and this we gave it as a complete transposition of great vessels. So the 3-vessel view will give us what is called as a reverse boomerang sign or I sign of the aorta, and it will also show us the baby bird beak sign in the LVOT view, which is what we saw earlier. So remember, the I sign is what demonstrates the reversed convexity of the aorta in the 3-vessel view, and the baby bird beak sign is the LVOT view, which gives rise to the PA and the branch PAs, which looks like the branch PAs looks like the open mouth of a baby beak. So this is a baby beak view. That's the autopsy. You can see that this is the cardia. Normally the anterior vessel which is seen is the pulmonary artery, but here you can see that's the RV and that's the aorta. So what is the proof? You can see that's the RV, that's the aorta, which goes into the arch, gives rise to the great vessels and turns down as descending aorta. So that says that this particular vessel is the aorta, but it is coming out from the right-sided chamber. Also look at the other vessel which comes out at the same level of the initial aorta, and this branches, and this is the pulmonary artery. So you can see that there is loss of crisscross. Both vessels are parallel to each other. The aorta is anterior, the pulmonary artery is posterior. Okay. Also this autopsy showed that there was a coronary anomaly. The LCX and RCA had a common origin, and also we could see Meckel's and the appendix in this autopsy. So that's the transposition of great vessels shown to you in detail. So you can see another autopsy specimen where transposition was seen. So that's the aorta coming out from the anterior chamber, and that's the pulmonary artery coming out from the posterior chamber. So this was another fetal heart which also had a TGA. Interested students can refer to the refer series under MEDIKNIT. My number is 98441 29465. You can WhatsApp me for further learning, and you can take my courses under the refer series. I have a course on fetal echo, on fetal aneuploidy, etc. Happy learning. Before I finish, I would like to say that this case, which we meticulously diagnosed perfectly as TGA, had 3 other anomaly scans done elsewhere where every report said the heart was normal. So obviously the 3 scans get a majority and my scan gets a minority. So the patient refused to believe that there was a cardiac anomaly because 3 other radiologists said the heart was normal. He challenged me and threatened me to go to the police. I said, you can go wherever you want, but your child has a cardiac anomaly. So why I am explaining this to you is because it is an anomaly which is very easy to miss. So please be careful when you look at the LVOT and RVOT shapes. Try to pick up the small deviation in the shapes of the LVOT, RVOT. Always show the branch pulmonary arteries and make sure that the vessel you're calling as the pulmonary artery is not the aorta. Thank you very much for a patient hearing and learning. Dr. Pradeep Srinivasan from Bangalore. Jai Hind.